Well, you're right. We will root for him.
How many seniors? Can you put up your hands? Third years? Just one, huh? Alejandro's coming. He told me, you know, I wanted to give you guys 10 minutes, you know, so fascinating that it's a review, right? And I have all the second and first year medical students here.
Well, we take the ITE in July, so it's a good review for us too.
Okay. You know, I remember many years ago when I was a third year resident, finishing my residency and thinking about my boards. I went to my seniors and asked them, hey, how do you prepare for boards? People who are passed. Residents, I sat down and I picked up constipation, reflux, inflammatory bowel disease, celiac disease. I gave a 5-minute discussion on it and then moved on. So I was told that residents like questions, right? So this year we're doing it different. We changed the format. So let's pick up a patient that who's going to do the first one. Aisha, why don't you start? I know you're eating. Alejandro had been here, I would have asked him.
As an interview boy is referred to by his school because of obesity. He has been in good health except for a rapid increase of weight for the past 2 years. During that time, his parents have noted change in his behavior and they're concerned about his core school performance. Because of declining grades and some difficulty in concentration on his studies, the young man recently was diagnosed with ADHD and has been treated with methamphetamine. Physical exam demonstrates a well-developed obese adolescent with height, longevity, and weight is 80. The only other findings of note are a firm liver edge palpated 2 centimeters below the right costal margin and a palpable skin. Initial lab results include hemoglobin 13, AST 60, ALT 55, alcohol 280, bilirubin 3.5, ESR 30. Because of these results, you obtain the following additional studies. Hep A is negative, Hep B surface antibody is positive, Hep B surface antigen is negative, Hep C antibody is negative, alpha-1 antitrypsin 220 is normal, serum cytoplasmin is also normal. Of the following, the most appropriate next study is.
Okay, so you know, if once you see this question, you get put out, right? When you see this such a big, I mean, there's a lot of sort of filling in there, filler. So you have to, what do you, before you go to the question, what strikes you the most in this? Alejandro, why didn't you tell us? I didn't just walk in. No, somebody else. Come on, I need a volunteer. So what hits you in this, whatever they've given you, what strikes you as the most important thing?
Declining school performance and obesity.
Sorry?
Declining school performance.
Very important. That's the single thing that hits me the most, that he's not doing well in school, this guy. Okay, number 2. What's the second thing that strikes you?
Recently started methylphenidate?
No.
No?
Yeah. Sorry? No. I mean,
Liver, palpable.
go ahead. Sorry?
Palpable liver.
No. Before that, before you go to the labs.
Liver edge.
Hepatosplenomegaly, exactly. That indicates chronic disease. So that's your tip off is there. There's a lot of stuff there. So you have to quickly discern what is important, what is not. There have been some behavioral changes, and there's liver and spleen palpable. When you get a spleen palpable, it means chronic disease. When I see hepatosplenomegaly, I'm thinking, is it portal hypertension? That's my first question. Okay. Then hemoglobin is fine. AST, ALT, the mildly elevated. Alkaline phosphorus is abnormal. Billy is 3.5. Doesn't. The next thing that hits me is the SED rate. So there is an inflammatory process going on in addition to whatever there. Okay, so what you're thinking with that SED rate is, does this child have IBD, which also would be reasonable, but there's no other GI symptoms, right? So the first order of business is hepatitis A, B, and C ruled out. Hepatitis B surface antibody positive means that the child had hepatitis B in the past or has had vaccine. Okay, alpha-1 antitrypsin is normal, but in the context of sed rate being elevated, remember alpha-1 antitrypsin is an acute phase reactant also. It can be abnormal. So alpha-1 antitrypsin indicates to you you're thinking of alpha-1 antitrypsin deficiency. So if you're thinking of alpha-1 antitrypsin deficiency, the most specific test is PI typing. So you should have PI-ZZ, but not, in any case, that's not that accurate. The next thing over there is ceruloplasmin. What does ceruloplasmin mean? It's 22, it's in the normal range. What does it mean? Sorry? Wilson's disease, right? But remember, you have to look at that ceruloplasmin in the context of the sed rate, that it is also an acute phase reactant. Okay? So having said that, they give you 5 choices: abdominal ultrasound, Epstein-Barr virus titers, liver biopsy, serum copper measurement, and slit lamp examination. Okay, I want one of the first years to pick an answer. Let's see. Dr. Iqbal, go for it.
Okay. I don't know what I'll show you. I'm not leaning towards the liver biopsy too.
Fix it for the next step.
I mean, I'd be between D
You have to go through a thought process very quickly. Abdominal ultrasound is going to help me. I already know your liver, hepatosplenomegaly. So Epstein-Barr virus, could it be? Usually my experience in older children has been Epstein-Barr virus causes hepatitis anicteric. This is icteric. So possible liver biopsy, what you're looking for, serum copper measurement, slit lamp exam, all 3. What do they mean? What direction are we going? They're already taking you in a very good direction. They question the way it's placed, right? It's Wilson's disease, right? So what test would be an appropriate test in this person?
Slit lamp.
Sorry?
Slit lamp.
Slit lamp exam, very good. That's the answer that they wanted. A slit lamp. So you need 3 components to make a diagnosis of Wilson's disease. One is the ceruloplasmin, the second is the slit lamp exam, and the third is urine copper. If you have those 3, then you have a diagnosis. You don't have to go to liver biopsy. If that is confusing, then you go to liver biopsy. Serum copper is not a good test. It's inaccurate. Got it? And Wilson's disease is one disease you can't afford to miss. Okay, I remember in my days as a fellow, somebody was sued. There was a psychiatrist who had seen somebody with behavioral changes, and the child ended up getting end-stage liver disease. If you don't treat, then it's going to progress to end-stage liver disease, and the patient is going to die. So 2 implications, in my opinion. Wilson's disease is an autosomal recessive disorder. If I diagnose an index case, I'm going to check the other family members. And remember, Wilson's disease you start thinking about after age 10. Because what happens is that there's a defect on chromosome 13. As a result of the defect, the liver is unable to excrete copper. So copper builds up in the system. Initially it'll load the liver, and then it'll go on to load the brain and other organs. Wilson's is also known as hepatolenticular degeneration. Lenticular meaning the brain. And what you get in the eye on a slit lamp exam is KF rings, Kaiser-Fleischer rings. That's because of deposition of copper. Any questions? So this is a very important disease, and you know, if I was an examiner, I would think about that. Okay, Alejandro, yours.
3-year-old boy presents with a temperature of 39.5, first time during a seizure. For the past 3 days, he has had 8 to 10 loose liquid stools and abdominal pain. He attends childcare and several other patients. All other children in the center have been reported to have diarrhea. But the following the most likely cause of the child illness is an infection with A. Campylobacter jejuni, B. rotavirus, C. Salmonella enteritis, D. Salmonella typhi, E. Shigella flexneri.
Okay, Alejandro, give me an answer.
I guess, yeah.
No guess. There's no guess.
The Shigella, I mean, because of the all the other, because Shigella needs a really low, to spread, and no other kids have the.
But there were seizures. No, you're missing the point.
I mean, no seizures too.
The point is that the fever and seizures in a 3-year-old. You know, you don't see Shigella as we did. It's of the 4 types. Flexneri is the most difficult to treat. That's the one you see in this country, and that's Shigella gives you high fever and gives you febrile seizures. So none of the others are going to do that. It's a very easy. If you get this question, it's a giveaway. Okay, rotavirus usually won't, salmonella won't. The two salmonellas and Campylobacter jejuni. When you look at questions carefully, when they give you the same or something, that's excluded. Salmonella, unlikely. So then you're left with three. I mean, in my book, I would think of rotavirus or Shigella. If I didn't know, I would choose from those two. Okay. High fever, sudden rise in temperature causes a seizure. Anybody? Who else is a third year here? Important, and then move on. I mean, the perinatal history is, I think, not relevant. It may be relevant in that it's not a premature baby, and so on and so forth. But so, you have 5 choices. What do you think is the right one? Yeah, that's the right one. Because this child is being fed a lot. The normal volume for a 6-week-old should be about 2 to 3 ounces, maybe 4, 6 ounces a lot. That's number one. Number two, the event occurred immediately after feeding. That's a giveaway. That's reflux aspiration. And remember, ALTE and associated reflux is very controversial. They're very difficult to prove the cause and effect. So when you have some of you have called me on occasion, consulted me in a PICU if we have a baby with ALT and we need your input, and I always tell you it's very difficult to make the association, but think of 4 or 5 conditions. Think of cardiac, think of neurologic condition, seizures, think of acute viral infection, and think of GERD. And the easy thing is, if you find nothing, I would go ahead and treat them like GERD. And in this child, it's much easier, the volume. I would decrease the volume, and if they gave me a choice, I would thicken the formula. Because that's the basic management of reflux, in small babies. You thicken the formula so that you don't have as much coming up, and you decrease the volume to physiologic volume. That's the approach. Pharmacologic therapy comes next. Okay? Any questions here? I think, does anybody have a problem with this format, or is it too simplistic? Sorry?
No, it's good.
Let's go next. Okay, anybody, any volunteers? Abu Gisa, right?
Close enough.
Tell us, yeah, what is the important relevant history here that you take from this story?
The change, the adding the formula.
Formula results in more loose stools.
Well,
right?
no, it's just yeah.
Yeah, number one. And what else is relevant there? Before you go to the
fall off in the weight gain.
Fall off in the weight gain. What else is important? There's a diaper rash.
The diaper rash.
What does the diaper rash tell you? Sorry?
Like that there's skin involvement or improper healing.
So what condition what will give you that?
Zinc.
Sorry? Zinc deficiency. But you get more echo, What they're trying to say there is that it's acidic stool. Acidic stool.
Okay.
Common, yeah. Because there's a very common thread in that story. Okay, so you have 5 choices. Alejandro.
Nah.
I'm going to pick on people who did GI rotation with me in 30 years. No, you're a GI fellow now. Well, you come to my clinic and you act like a GI attending.
I don't know, because of the weight loss, I would think maybe CTE have to run subject to this.
Mm-hmm. Mm-hmm.
Because if you have lactose intolerance,
Okay, let's look at the test. Okay, what is the most outlandish test over there? I like to go through process of elimination. What is the most outlandish test? D-xylose absorption test. Does anybody know what D-xylose is? Sorry?
It's not absorbed.
Yeah, it's a molecule that's not broken down in the gut. So if your mucosa is intact, that you don't have any villus damage, it will be absorbed and excreted in urine. So you can collect the urine or even the blood 1 hour later, and you get a certain value. If it is below that value, you interpret that there's damage to the villi. Okay. When we didn't have endoscopy, the tool of endoscopy in the olden days, in the 80s, and we are thinking of celiac disease, we did this test before doing the capsule endoscopy. So now that we have endoscopy, we don't do it. So that test to me is outlandish. The question is, does this child have malabsorption? Yes or no?
Carbohydrate malabsorption.
Carbohydrate malabsorption. Very good. Okay, so you narrowed it down. Can be protein malabsorption, it can be fat malabsorption, it can be carbohydrate malabsorption. So you rightly narrowed down the carbohydrate malabsorption. Why? Because the stools are watery. Number one. Why? Because there's diaper rash. Okay, if you get acidic pH in the stool, you'll get diaper rash. So having said that, what condition will give you carbohydrate malabsorption that you want to test for? Tissue transglutaminase, will that give you carbohydrate malabsorption only? No. Right? So that's a test you're not going to do. Zinc, I told you it's more ectodermatitis. That's out. So how about lactose tolerance test?
But she's too young for that.
No.
No,
No.
it doesn't get better with soy.
He's on a soy formula, which is lactose free. It gets worse. So lactose out. So you are left with what test?
Breath hydrogen.
That hydrogen test. This patient, you're suspecting sucrose isomaltase deficiency. And remember, that is the commonest disaccharide deficiency, a congenital deficiency that you see in children. So what is the definitive test to diagnose sucrose isomaltase deficiency? Biopsy. That's the definitive test. But if I had a blood test positive, I would not go to endoscopy. I would just put the child on sucrose isomaltase free formula. Questions, anybody?
So typically, Dr. Kagalwala, do they present, like, what age do
They
start presenting?
depending on when they get challenged with that kind. As long as this child was on breastfed, there wasn't any cornstarch solids in the formula. That's why there's no problem. It can be a year, it can be 2 years. It can be. We sometimes see them as adolescents. They come with abdominal pain, recurrent abdominal pain, with diarrhea, and we diagnose them with sucrose isomaltase deficiency. If a suspicion index is high enough.
What would go against, celiac besides the fact that the stools maybe be acidic, but usually patients present with like failure to thrive and diarrhea, right? And then he's getting like rice cereal, all that stuff. So.
They don't tell you that. See, the fact that it's just watery stools is supposed to be a tip-off in this patient. But yeah, I would have narrowed it down to tissue transglutaminase and breath test. Those would be the two tests that I would have picked from. Anybody, somebody?
I need to know girl presents to the emergency department after vomiting some coffee ground material. Her past medical history is significant from juvenile idiopathic arthritis, diagnosed at 8 years of age. Illness has been put to control and has required long-term corticosteroid use. Currently, she is taking 20 milligrams of prednisone daily, plus 2 milligrams of naproxen twice a week. A recent DEXA scan demonstrated significant vertebral bone loss. Follow-up spine radiographs demonstrated a variable fracture, and therapy with alendronate sodium was started 2 weeks ago. Her medications are usually taken at bedtime. She was in her usual state of health until last night, when she was awakened by sharp mid-substernal chest pain. She vomited once, and the vomitus contained mostly clear fluid plus 40 grams of variant particles. In the emergency department, she complained from substernal to her heart rate is 90 beats per minute, and her blood pressure is 126 over 84 millimeters of mercury. Initial lab data for the third include the following: hemoglobin 12, 13,000, latex score.
Important things that you glean from this story. Sorry?
She was recently started on Olympiad.
That's what, so if you take away from that, that's
Well, not the
red flag. No,
I mean, that she has like a chronic
It's
condition.
esophagus thing, so it
Yeah.
would go with esophagitis, and then that alendronate is what was the new thing that was.
so that's a red flag for you. It's like a flashing light, right? It was a flashing light for me too.
Okay.
Okay, so there are two things that flash before me. One is the alendronate, and what she also was taking, what was it?
Naproxen.
Naproxen,
Yeah.
right? Those are two things that stand out to me. I mean, I'm thinking in my mind, these are possible causes for the upper GI bleed that the patient had. Agreed? Anybody have think differently? And then they gave me choices. So a barium swallow, a radiologic study, upper GI, what's it going to tell you in 2015? That's I would have done that in the 80s, but not now. Beginning treatment with misoprostol, but you don't even know what's going on, right? So that makes no sense. Decreasing prednisone 10 million. No, this patient needs prednisone because of the condition she has, right? Then you're left with discontinuing alendronate or referral to emergency upper endoscopy. Those are two choices. As a gastroenterologist, my gut is always endoscopy, right? That would be the flashing light. But the answer is D. Stop that medication, right? That is the more important. I mean, you have to pick and choose. The other thing you have to remember is that when there's a question in the exam, you have to put yourself in the examiner's or the person's shoes. Oftentimes you don't get lucky. Like Alejandro said, the previous question, that he thinks it should have been TTG. I may agree with that, but that's not what the examiner had in mind when he put that question. He gave you certain clues, and you are supposed to glean what he wants or what the examiner wants. It's not sometimes the right answer may be between two. And you have to pick. You have to be lucky to pick the right one. So you go to the next one. Sorry. Okay, this is a good one.
While performing a newborn exam 18 hours after birth, the mother relates to you that her son has had small green emesis after each of the last 3 feedings. The infant was born at 39 weeks gestation by spontaneous vaginal delivery that was complicated by moderate meconium-stained amniotic fluid. He emerged vigorous and did not require endotracheal suctioning. Since birth, he has been fed a cow's milk protein formula every 3 hours and has had 2 wet diapers and 1 stool smear. Physical exam reveals an alert infant with a soft, non-distended abdomen and an externally patent rectum. The infant has another emesis of bilious material immediately after your exam. You obtain an abdominal radiograph that is interpreted as normal. Of the following, the most appropriate next step in management of this patient is to...
Tell me your name again.
Alex.
Alex, what is the most important clue here that they're giving you? Just one. Exactly. They're telling you that this child is having bilious vomiting, is a newborn. And bilious vomiting in a newborn is always pathologic till proven otherwise. There's no two things. And this is the type of question that you should get in the exam, because you are going to see newborns as a primary care physician, right? So they give you multiple choices. Please read them. So
catheterize the urethra for a urine culture, observe the infant for additional symptoms, obtain abdominal ultrasound, perform an upper GI series, or prescribe a complete milk protein hydroxylase formula.
Okay, Alex, I've always found you, when I come to the floor to see consults, I've always found you to be very clear, coherent, and intelligent. Mm-hmm. So, what is the most outlandish? Sorry?
The most. So you better not get it
No. So, what is the most outlandish thing over there of those 5? Just take it out.
The most outlandish would be catheterized.
Yes, I agree. It would be a traumatic procedure. I mean, that's most outlandish. Why would I? I mean, if you answered that, maybe you should come back for the board, right? Okay. How about what else is outlandish there?
Observe, because they've already had several episodes.
Multiple, and you've seen one, right? And then what is the next outlandish thing that you wouldn't do?
Prescribe the complete milk.
Yeah, because it doesn't sound like cow's milk protein allergy, right? So you're left with two choices, abdominal ultrasound and perform an upper GI series. And you know, I mean, those of you who have done rotation with me or who have talked to me know my thought about these 2 procedures, right? So which would you pick, Alex?
I would perform an upper GI.
Upper GI. So upper GI, I mean, here I'm thinking malrotation. So your differential would be somebody will say, well, malrotation and pyloric stenosis. Pyloric stenosis doesn't give you bilious vomiting because the obstruction is higher. It gives you recurrent vomiting, but not bilious. And I'm not a fan of ultrasound even for pyloric stenosis. I like upper GI because it gives you more information. It tells you about malrotation. It tells you more information about the pylorus than what an ultrasound can. So malrotation, one of the commonest congenital anomalies that you see. What does malrotation do? What is the complication of malrotation? Because you can have normal people go through their life with malrotation and you find it incidentally on post-mortem and nothing happened. So what, sorry, somebody said something? Volvulus. And volvulus and delay can lead to necrosis and death, right? So at every instance you want to do an upper GI, there's malnutrition, you want to consult a surgeon, they'll go in there, they'll take the lab bands out, and they'll place the the cecum in the right position. So what happens in malrotation? You do an upper GI normally, the esophagus, stomach, duodenum, the fourth part of duodenum, it loops. It loops like this in 3 dimensions. It goes up and backwards and then down. So it crosses the midline. And there's an attachment called ligament of Treitz. That's the fixed point where the fourth part of the duodenum attaches and the jejunum starts. So that's what radiologist is looking for. Is that attachment there? If there is not, then he says, there is either partial or complete malrotation. Okay? Malrotation. What are the conditions associated with malrotation? Sorry? No, what conditions what syndromes are associated with malrotation?
No, like underlying conditions.
Underlying. Sorry? Trisomy 21? Trisomy 21? No. Associated with malrotation, Hirschsprung disease? Yeah. And there's several other syndromes. Look it up. Malrotation. I mean, this is again another given. It's an easy one. If you get a question on malrotation, it's an easy one. It's a gift. You can't go wrong. Okay. Ma'am.
70-year-old boy who had a laparotomy for complicated perforated appendicitis 2 weeks ago has developed diarrhea and a fever of 39.5. He has been receiving IV antibiotics since surgery. On physical examination, he is diaphoretic with a heart rate of 135 beats per minute, a respiratory rate of 25, and blood pressure of 960. His weight is 70 kg. His conjunctiva and oropharynx are clear, but mucous membranes are dry. Auscultation of the chest reveals decreased breath sounds in basis bilaterally. Cardiovascular examination reveals tachycardia with a normal reading and no murmur. Pulse rates are equal throughout, but capillary refill time is approximately 3 seconds. Examination of his abdomen reveals distension, active bowel sounds, and diffuse tenderness. Results of the remainder of his physical examination are unremarkable. Of the following, the test most likely to establish the diagnosis is stool toxin.
Sorry? You want to stop here? So, like when this is a post-surgery, right? Why the hell are you calling me? Why don't you call a surgeon, right? That's my first reaction. But no, it's a medical issue. So what strikes you?
Antibiotics.
The antibiotics is a tip-off, right? Okay, so the answer is? Agreed. C. diff, right? And what's the treatment of C. diff? Sorry? Metronidazole. What's the second line treatment? Vancomycin. Okay. Okay. Tell me your name, and I'm sorry, I'm bad. I don't know. Sorry. Please.
A previously healthy 9-year-old boy presents in the emergency room with epigastric abdominal pain, fever, chills, vomiting, and jaundice. On scan examination, the boy appears uncomfortable, has a heart rate of 100, a respiratory rate of 20, spiral icterus, and palpable mass in the right upper quadrant. His past medical history is significant only for intermittent episodes of abdominal pain and vomiting that were thought to be secondary to viral gastroenteritis. Initial lab values show the following: hemoglobin of 14, WBC of 19,000, platelets of 500, AST is 140, ALT is 125, GGT is 450, alkaline phosphatase is 545. Total bilirubin is 10, direct bilirubin is 7, amylase is 5,000, lipase is 12,000. Of the following additional diagnostic studies, are most likely to demonstrate. Of the following additional diagnostic.
Let Alejandro take this one. He's an expert on this.
Oh,
Go ahead. I'll get you another one. But let this Alejandro take that. Think about it. So you have a 9-year-old male, not a female. They don't tell you that. Who goes to emergency room with acute onset of epigastric abdominal pain, fever, chills, vomiting, and jaundice. Acute onset. They don't tell you it's long-standing. And The only other relevant history is that intermittently it had some vomiting and abdominal pain, which was diagnosed as viral gastroenteritis, right?
What was the mass?
And then he has a mass in the right upper quadrant.
So,
And then he has elevated amylase and
when you have
lipase.
gallbladder disease and like stones, you don't have usually a mass that you can
Mhm.
So I guess A would be the answer.
A is the answer.
Okay.
Very good, Alejandro. I thought you were going to pick B.
I told it.
But B would be something I would have thought about, but the tip of there is chronic cholecystitis. It's not chronic. Cholecystitis is not chronic. The mass is choledochal cyst. Choledochal cyst is cystic dilatation of the extrahepatic biliary tree. It's a congenital condition. It can present in newborn in 25% of patients. It can present at any age after that. Sometimes adults too. In your patient that you had, there was suspicion of choledochal cyst, which they did not find.
Yeah. And
The
that
one-
gives you a superior risk for developing cholelititis.
You can develop stones in there. Yeah.
Dr. Nagalala, why are the amylase and lipase so elevated?
Because you got pancreatitis also, the stasis.
Okay.
Secondary,
Yeah.
some sort of infraction.
So
Yeah.
is it choledochal cyst like there are different types? There are like 5 types.
4 types.
4 types.
Yeah.
So like 3, 1 has to.
Yeah, yeah.
3.
Go read it. I can't.
Intrahepatic involvement also.
It can be secondary because of the stasis, you can get cholangitis and damage. But mostly, by definition, it's extrahepatic. The intrahepatic is Caroli's. It's a totally different condition. So if it's intrahepatic bile dilatation, I think a Caroli's. Yeah.
So that is the type of choledochal. The choledochal cyst is only
Extrahepatic. Yeah. And the reason is because there's a weakness in the wall. So in time, that because of weakness it dilates. Like you get people who have aneurysm and it ruptures. Same thing here. It reaches a max point and then it can keep on dilating and pressing on the extrahepatic biliary tree. Again, this is a very in a newborn. Whenever people call me for a consult, we have a child with newborn or a 2-week-old with jaundice. The first thing I tell you is, did you get an ultrasound? So I'm looking for choledochal cyst. That's the reason. In liver, like in GI, you want to quickly rule out the treatable causes which untreated can lead to complication. And choledochal cyst is one of them. The earlier you diagnose, the less likelihood of complication, just like biliary atresia. Okay, you can move on.
Again.
Yeah, I think I asked. This is yours.
14-year-old girl presents in the emergency department because of a single episode. The medical history is unremarkable except for an episode of nausea and a passage of a black stool yesterday. On scar examination, his afebrile, pale, perforated. There's a 2/6 polysystolic adenoma and orthostatic changes in both pulse rate and blood pressure. Abdominal examination reveals no hepatomegaly and a spleen tape palpable 2 centimeters below the left costal margin. Rectal examination showed that hemocult positive stool. Initial lab data demonstrate the following: hematocrit of 24%, platelets of 80, VUN of 32, pine of 1.0, PT is 12.8, INR 1.1, serum electrolytes are normal, glucose is normal, AST 60, ALT 75, albumin 4.0. Her vital signs have improved and demonstrate no orthostatic changes after receiving a normal feeding intravenously. Of the following, the best next step in the management of this patient is to order a blood smear for tryptocytes and breast cells, CT scan of the abdomen with contrast, MFL scan, leads to gastric intubation, and a tap red blood cell scan.
So what are the important
Yeah.
clues that you glean from this?
The blood stool.
What does black stool mean to you?
So she hasn't eaten.
Thrombocytopenia.
Sorry?
Thrombocytopenia.
No. Stay with the black stool. What does black stool mean to you? Where?
GI upper
Where?
in the
About the ligament of Treitz.
Yeah.
Because that's been altered by the acid. So black stool means that the bleeding is coming from higher up. Number one. Okay? Good. And then what else have you got there?
The spleen tip is palpable.
So spleen tip with thrombocytopenia tells you that there is hypersplenism.
Yeah.
And there's hepatomegaly, right? So there is a liver disease, an ongoing liver disease, right?
No, there's no hepatomegaly.
no
Only the
hepatomegaly.
spleen tip is palpable.
Oh.
Splenomegaly.
No hepatomegaly.
No hepatomegaly. Okay.
Yeah, so that just means that this.
So you have
is
spleen
trapping.
palpable, and you have somebody with what looks like upper GI bleed, right? And you have thrombocytopenia, right? And the liver enzymes are off slightly, so that tells you there's a hepatic involvement, right? Okay. So what is the best next step for the management? Would it be a blood smear for cystocytes and blood cells? What do you do that for?
Hemolytic anemia.
Intravascular hemo. Okay. CT scan. Sorry? No? Meckel scan? How about a red cell scan? Because there's no acute bleeding. You need, in order to do a red tag scan, you have to have active bleeding. It should be more than 1 cc per minute for you to pick it up. So this patient's got altered blood, right? So what's the right management here? NG.
NG, figure out where it's coming
Yeah.
from.
Is everybody clear about that? Given the choices, this is the best answer. That's what they want to know. You want to put an NG tube and do a gastric lavage. See if it's what you get. Do you get bright red blood, and then you'd have to go and do endoscopy, right? Okay. Ma'am.
A 12-year-old boy suffered severe abdominal injuries after he was struck by a car while on the go. On his first day of hospitalization, he underwent expiratory laparotomy that revealed no damage to his liver, pancreas, gallbladder, or intestine. Since then, he has remained on TPN. Today, he has a fever of 38.5 and right upper quarter thinner. On examination, he has decreased bowel sounds and abdominal guarding. Lab studies revealed the following: elevated WBC bilirubin 2.5, AST 110, ALT 85, amylase 650. Abdominal ultrasound is ordered and shows a thickened, distended gallbladder with infraluminal sludge but no stones. The common bile duct is not well visualized, but the intrahepatic ducts are not dilated. The pancreas is obscured by increased bowel gas from what appears on a supine radiograph of the abdomen to be an adynamic ileus. No free air is needed. Of the following, the most likely cause of this type of symptoms is acute cholecystitis, acute pancreatitis, ascending bacterial cholangitis, acute peritonitis, or a perforated ulcer.
What is the most outlandish answer there?
Perforated ulcer. There's no ulcer.
Yeah, because there's no abdominal distension, there's no guarding, there's no rigidity, right? How about bacterial peritonitis? That's also outlandish. It should be tender, right?
It's also there.
Right. So what do you think is the right answer there? Sorry? But there's sludge over
I
there.
think it's bacterial cholangitis.
This is a tough one. I know what the answer is, what they want, but it's a tough one.
I'm going with cholangitis.
That's the answer they have. I would have picked up cholecystitis, but that's, what's against cholecystitis is the fact that there's pancreatitis also. They should give me both. So that's the answer. C is the one that's closest to the right answer here. Yeah, cholangitis.
What's the difference between why cholangitis and not cholecystitis?
Because you have to
Because there's pancreatitis also. Cholangitis will include inflammation of pancreas, but not the other way. Acute cholecystitis would not. It would be just when you have amylase elevated, that's an additional.
Yes.
Well, with cholecystitis, will give you also the elevation in the ALT and AST. Maybe not, right?
Maybe not, maybe not. So that's against it. Yeah.
Okay.
The 12-year-old girl presents to the emergency department for oral pain. She was discharged from the hospital 1 week ago after receiving her first course of high-dose methotrexate for osteosarcoma. She has been unable to eat or drink because of painful oral ulcers in the sore throat. She She does not have a history of previous oral ulcers. Temp is 37.2, pulse is 110, respiratory rate 22, and blood pressure 130 over 85. On physical exam, she's pale and alert. Her lips are dry with no lesions. There are multiple erythematous oral ulcers on the tongue and buccal mucosa. Pharynx is also erythematous, but there is no tonsil or exudate. The remainder of the physical exam findings are normal. The following are the results of her lab tests for the girl. White count, 2,200, neutrophils 5%, 79% lymphocytes, 13% monocytes, 3% eosinophils, hemoglobin 7, platelets 30, BU120, creatinine 0.5, glucose 65, sodium 132, potassium 3.2, chloride 98, and carbon dioxide 17. Of the following, the most likely cause of oral findings is A. Candidiasis, B. Group A streptococcal infection, C. Herpes simplex, D. mucositis, or E. Poor oral hygiene.
No, this question should have been in hem-onc. This is right. Why GI? But sometimes there's no overlap. There's no overlap because of methotrexate, pretty much. Because there's a. So, what's the right answer? Sorry?
Mucositis.
Mucositis is the right answer. It's not herpes simplex and it's not candida because there's no exudate. And also, the giveaway is 1 week ago the child had received methotrexate. Between 5 to 10 days of receiving methotrexate, you can get mucositis, break in oral lesions, right? And the treatment is just good oral hygiene, I guess.
Nine-year-old boy is brought to your
Oh, you still want to go, huh? Wow.
Okay, a 9-year-old boy is brought to your office after several visits to the ED because of severe abdominal pain. During these episodes, numerous blood and urine tests were obtained, and all the results of these studies were reported to be within reference limits. During one of these episodes, the boy vomited a large amount of yellow-green material, and the pain resolved shortly thereafter. Physical exam demonstrates a happy, well-appearing child whose height and weight are both at the 75th percentile. His abdomen is soft, non-distended, non-tender, and without masses or ganomegaly. Results from the remainder of the physical exam are unremarkable. Of the following, you're most likely to recommend A. Abdominal ultrasound, B. A referral for endoscopy, C. A referral to the psychologist, D. Routine follow-up with instructions to call immediately if symptoms recur, or E. An upper GI radiographic series.
Do you feel qualified to pick an answer?
Sure.
Sure? Wow. Then you don't have to do a GI rotation. If you really right. You pick the right answer. The commonest cause, of abdominal pain in children is functional. Okay? I do send a fair number of my patients to see a shrink. Particularly girls who are cutters or depressed, and I just can't, I can help them, I can make the diagnosis, but I can't make the pain go away. So I do send them, allow them to psychiatrists. There's a red flag over here in this story. Okay? Sorry? Bilious vomiting. Bilious vomiting. So you have to read in between lines sometimes. Everything else is pretty hunky-dory. So what do you say the right answer is? What were you going to pick before I open my mouth?
Oh.
Refer to a psychiatrist, right?
No. I was actually going to say A.
Abdominal ultrasound. What will abdominal ultrasound tell you?
Because he's in the ED and he'll feel his vomiting, abdominal pain.
So no, what will ultrasound show? Tell me.
Yeah, I don't know.
After, does everybody speak Hindi over here? From India?
Yeah.
वो राम कहानी पूरी हो गई और पूछते कि राम कौन है? Means, you read the Bible and say, who's Jesus, right? That is what you did. So you have to do a GI rotation. I'm just making a little light humor. I'm not picking on you. Okay, Aisha, help us. Yes, that is the answer. Because routine, everything else is chaff. Give upper GI and he'll have malrotation, refer him to surgeon, fixed. Because next time around, he may have had volvulus and might have died or gone into shock. Right? Okay, let's see. I want to pick my favorite question if it's there. No, it's not. Okay, let's do a few more. We'll go over if you don't mind. Can we?
An 9-year-old that presents to the emergency department with jaundice. He was born at terror by spontaneous vaginal delivery after an uncomplicated pregnancy. He was exclusively breastfed in the hospital and was discharged 48 hours after birth.